let's start by asking ourselves, why do we need alternate alignments? I think the current concept or the current argument is patients are unhappy. I've had the privilege of scrubbing with the two Johns, John Insel and John Charnley. So I go back a little bit in terms of my commitment to my understanding of these philosophies. I also have a very great, very dear friend in Bob Booth, and he says patients are unhappy natively. Some happen because you do bad surgeries, some happen because you've chosen the wrong patient. And in a lighter manner, he actually talks about a spinster who comes in a broad daylight wearing dark glasses into your room is a patient who you should probably never touch. So what alignment goals are we aiming for? Look at the options: anatomic, mechanical, adjusted mechanical, kinematic, restricted, inverse kinematic, constitutional, personalized, and CPAC, and 9 of the CPAC. I did not have enough room on that slide to put all 9 there. So I would have needed an extension of the slide, and unfortunately, PowerPoint did not permit me to do that. Look at the two philosophies. The kinematic, my good friend Stephen Howell, with whom I've debated this very topic at the CCGR, ignore anatomy and prioritize, and the mechanical alignment of John Insel. So really, what are we looking at? We are looking at a total knee, which is an operative procedure. We do it because we hope that it will improve the patient function. And we're trying to see that the closer the knee can be to normal, the better the function of the patient will be. So why is alignment of the knee important? Because it decreases mechanical and shear stress that's basically placed on the bearing surface. It decreases mechanical and shear stresses placed on the bone cement interface and bone prosthesis interface. And we hope that it will help the balance the forces transmitted through the soft tissue envelope, which affects the functional outcome, which again brings it to focus whether the soft tissues need to be addressed. We, however, take away the fact that when we are doing a replacement of the knee, the kinematics are absolutely abnormal. ACL is deficient, sometimes PCL is deficient. You're changing the joint line, you're removing both menisci, and the geometry of the joint surfaces are altered. So a poorly aligned knee decreases implant survivorship, polywear gives you poorer functional outcomes, and early failures with component loosening. So the real sort of question that we'll be debating for the rest of the day today is, should knees be aligned with components at right angles to each other, which is our mechanical philosophy, or should the implant position recreate the anatomy of the pre-arthritic articular surface? The question really that you need to address is, how does one understand what the pre-arthritic articular surface or alignment was? So the second question we need to ask is, does non-mechanically aligned knees achieve clinical outcomes which are comparable or better? And how do limb and component alignment differ post-operatively between kinematic, which I've taken as a broad subgroup, and mechanical alignment? And is there a difference in reoperation rates between these two options? So in mechanical alignment, and I think Parag showed an absolutely wonderful demonstration of this. I'm not going to go into this. You get your rotation right, you do your tibial cuts, right angles, you do your mechanical alignment of the femur, adjust your rotation, various landmarks that you can see over here that Parag demonstrated to you. And then we have the kinematically aligned knee, where the primary goal is to position the femoral and tibial components so that they restore themselves to the patient's neutral alignment, and not to a neutral alignment that is unnatural for most of our patients. This was contrary to what we all know. This is not Stephen Howell. This is described much ahead of him by Ed Hollister. And it was popularized by Stephen Howell, and he put this anatomical concept of the true knee resurfacing, and he talked about patient-specific and ligament-sparing knee. And this was the X-ray that I argued with him at CCGR in Las Vegas. And I asked him how he would do this surgery using kinematic principles without doing soft tissue releases. He abused me later. And let's go back in time. And again, this is a confession of my age. When you look at it historically, these are all historical data. They talk about the need for neutral alignment. And some of you might argue a lot of things have changed. We don't drive Fiats anymore. We've gone to much better cars. But you look at the advantages that were purported as far back, almost 10 years, 12 years ago. High stresses is a risk factor. FEA model shows that neutral alignment has significantly less bone stresses, and whereas post-operatively negatively correlates with satisfaction. This is 2011 and 13, and some of you might argue, oh, this is archaic. It doesn't really work. So when we look at the mechanical alignment, again, and now we have more conforming articulation, but there's a definite lift-off, and again, when you look at work from people like Doug Dennis and Rick Comstock, there is a lift-off on the lateral femoral side in most of our arguments. So and these articles in 2016 alluded to the fact that a lot of these articulations will do well. Again, when you go back historically, 2009 and 11, the failure rates were much higher in a varus aligned knee. Let's go forward. Varus knees does not improve outcomes. Comparisons between KA and MA done any which way really show no real difference. KA is possibly an acceptable alternative. It's not an exclusive alternative. Clinical outcomes are at least as good and not better. Chit Ranawat's paper from 2004, from 2017, talk about kinematic alignment versus mechanical with as good, if not better, with mechanical. This is a condylar, this is now Kelly Vince's article. This is now a 30-year surviving articulation. Let's look at gait analysis. No real differences between mechanical and any other type of alignment at 5 years. Let's go further down. More gait analysis work from 2018. And when you look at this 2020 article from Nikki et al., patients with mechanical and kinematic, only 38 patients with K achieved higher functional scores with satisfaction scores comparable in both cohorts. More recent articulations, 2020, no difference in any outcomes. Does K improve short-term functional outcomes? No, it does not. 2018 articles. Retrieval analysis, again, you see when with mechanically aligned and kinematically aligned, there is more polyethylene wear, significantly more scores. Look at the alignment from the registry data point. Mechanical alignment remains the gold standard. This is the registry data. And you have further data on the mechanical axis. 90 to 99% were implanted by mechanical axis. I'll just take 2 more minutes, I'm sorry. And on an editorial, improving total knee arthroplasty, sometimes progress leads us nowhere. This was an editorial 2020. And earlier we talked about CR and PS, thank God that's gone out. Now we're talking about alignment, 17 options to choose from. Again, in RCTs, standard options work well over time. Clearly, there's no best way to do a knee replacement. And when we look at Joe Matar, and I strongly advocate all of you to read this article in 2020, there's absolutely no difference between mechanical or any other alignment. Very, very recent alignments, systematic reviews of RCTs, no significant difference between mechanically aligned, well done, and any other alignment. More such articles from 2023, as recent as 2 months ago, including the CPAC classification. As a final word, that good clinical results are going to depend on sound surgical technique and patient selection. Parag mentioned that, did that, demonstrated that. And this is my punchline. Hard to believe that alignment difference between 2 and 3 degrees between different alignments can explain poor outcomes, increase implant stress, and decrease survivorship. Thank you for your attention.